Good afternoon, everyone. Today we'll be completing with Complete Denture Part 7. Okay, today is going to be a little long lecture. We'll be completing two parts, that is Part 7 and 8, and we'll be completing the unit of Complete Denture completely today. Okay, so please, I hope you'll have had your lunch nicely and you'll are all with a lot of energy because we need to concentrate for at least an hour and a half maybe. So let's get started. Today will be the first part, that is part 7, will be discussing denture processing, denture insertion and post-insertion problems, and relining and rebasing. So the basic laboratory steps for denture processing are as follows, that is flasking, dewaxing, packing, curing, trimming, and polishing. All right. So these are the basic steps. First, we flask the denture, we keep it for dewaxing, pack it with acrylic, cure it for an hour or the long cycle for 9 hours, and then we are going to do the trimming and polishing. So I'll be just highlighting the major points which will be required from your multiple choice question point of view. I won't be going into detail of each of the steps, but whatever is important and is asked multiple times, I will definitely cater to that. So the different tin foil substitutes which are used are cellulose lacquers, aqueous solution of sodium silicate, calcium oleate, soaps and starches, and the okay, so it's also called as water soluble alginate solution. All right, so how does this alginate sodium alginate work basically? Is that the sodium alginate reacts with the calcium substrate of your cast or your flasking material. Therefore, it forms that kind of a layer which a separating media forms. Okay, that's how it reacts. Now, coming to packing and curing of acrylic. Now, when you're mixing monomer and polymer of acrylic, it should be always mixed in 1:3 ratio by volume. That is, monomer is 1, polymer is 3 times that quantity by volume. Okay, so the ratio is 1:3. That is, monomer polymer ratio is 1:3. The 5 stages of polymerization which are seen when we mix your monomer and polymer are: the first stage is the sandy stage, then is the stringy stage, then is the dough stage, then is the rubbery, and then is stiff. Now, why did I highlight dough stage? Is because dough stage is the most important stage for us. It is a stage where the mixture stops sticking to your fingers. Basically, when you're mixing it with your fingers, you will get to know when it reaches a dough stage. Okay, so that is the most important step. You have to pack the acrylic into your flask in the dough stage. Okay, if you pack it before, you will have a lot of monomer content which is present in your acrylic, which can cause porosities. If you pack it after the dough stage, it will not spread evenly. You will get a thick denture base, or it won't, you will not cover the entire base because the full flask will not close, because it will be in a rubbery stage. It won't actually go and attain the shape of the denture. Okay, so dough stage is the most important stage, and you have to pack it in the dough stage. Now, what is flash? Now, when we pack the two flasks together, okay, when we pack the two flasks together, the excess material what comes out is called as flash. Now, what is trial closure? When we are packing the acrylic into the molds of the flask and we close the flask for the first time, okay, for the flash to be removed, that is called as a trial closure. You can use a cellophane sheet to place between the two upper and lower flasks so that the flash comes out equally, and then you open the flask again, remove the the cellophane paper sheet, and then you close it again. So that first closure is called as the trial closure. That is to eliminate the flash or excess material. Okay. Now, what are the different curing cycles which are used? One is the fast cycle, okay, and one is the slow cycle, okay. So the fast cycle is you have to place the flask in a water bath, okay, at 70 degrees Celsius for 90 minutes, followed by 100 degrees Celsius for 30 minutes, okay. And the slow cycle is 70 degrees Celsius for 7 to 9 hours, followed by 100 degrees Celsius for 9 minutes, okay. So these are the two cycles which are basically followed most of the times. The fast cycle is followed, okay. um, Slow cycle is normally not followed nowadays due to time constraints, obviously. So most of the manufacturers, they make the acrylics for the fast curing cycle. Also, one more point to be noted here, I have written the degrees in Celsius. So they can also ask in MCQs, they can ask it in degree Fahrenheit. Okay, so you have to convert this and learn those values as well. 70 degrees Celsius is approximately around 165 degree Fahrenheit. Okay, and 100 degrees Celsius is approximately 210 to 212 degrees Fahrenheit. Okay, so you have to, whenever you're studying any values, always remember you convert it into the other units also, like the SI units or the other units. Remember all the values, because on the day of the exam you will not know the conversions, how much, how many kilogram, how many newtons is 1 kilogram, or that way. So always learn it in multiple units, so you will know the answer immediately. Okay. Now coming to the next thing, that is denture insertion and post insertion problems. So basically, post insertion problems can be classified according to the time of delivery. That is, it can be classified into immediate complaints, delayed complaints, or problems without complaints. Denture problems can also be classified as complaints about comfort of the denture, complaints about function of the denture, complaint about aesthetics, and complaint about phonetics, and other complaints. Now we'll be going ahead into each one in detail. I will be following this classification, okay? The 5 headings, that is complaint about comfort, then function, aesthetics, phonetics, and others. Coming to the first one, that is complaints about comfort. So the first complaint the patient can give you, or it's one of the most common complaints actually, it is sore spots, okay, also known as traumatic ulcers. Now what is the cause? Why do these sore spots happen? The causes in the vestibule area, if you see that there are sore spots in the vestibule area, it could be due to the overextension or unpolished or sharp edges of the denture. If it is over the alveolar ridge, it can be due to any high occlusion or any high point, or sometimes beneath the denture, like on the intaglio surface of the denture, there are acrylic blebs which go unidentified while trimming and polishing. So these acrylic blebs might cause ulcers onto the alveolar ridge. Okay. Now under the labial flange of the upper or the lower denture, it may be due to excessive overbite, or a labial flange extension, or any bony prominence, especially in the upper anterior surface. We always see a deep undercut. So maybe because of that, you see traumatic ulcers because of the undercut present in the labial area. Now, under the lingual flange, when we see, this is a classic sign of when CO is not in harmony with CR. There is a typographical error here. It's not CD, it is CO. That is centric occlusion. Okay, CO, that is centric occlusion. Centric occlusion is not in harmony with centric relation. That is when you see ulcers in the anterior lingual flange of the lower denture. Anterior lingual flange of the lower denture. Okay, this is a very classic sign which is seen when centric occlusion does not meet with centric relation. Then other reasons could be overextended flange or the prominence of the mylohyoid ridge. Then, now if sore spots are seen in the maxillary denture, that is in the posterior area, it could be due to the posterior valve seal, that is a PPS, that is too deep or too sharp, or due to an overextension. Now, if you see generalized soreness on the ridge, it could be due to excessive vertical dimension, generalized overextension, or inaccurate denture bases. Now, if your denture bases are not stable, they are not fitting onto the denture area properly, there will definitely be definitely be a lot of movement that happens of the denture base while mastication, while talking, while doing any kind of functional movements. So because of the instability of these inaccurate denture bases, ulcers can form across the ridge, generalized in a generalized way. Okay, so that completes the sore spots. Now, how can we manage these sore spots? What has to be done? Now, this chapter, right, regarding post insertion problems, it's a very logical kind of or a practical kind of subject. Okay, you don't need to by heart all these points. Today, there will be a lot of points being discussed. You might feel that, oh my God, how much do I have to remember? No, you just have to apply your mind. Just think of it in a clinical point of view. Okay, what will you do when there is an acrylic web? Obviously you're going to trim it out, so you don't need to by heart these kind of things. You will know it automatically. So now in the vestibule area, if you have a sore spot, what will you do? Because if it is because of an overextension, you will adjust the denture. Okay, and you will polish the denture. If you see generalized soreness, you will reduce the vertical dimension by making a new dentures. Okay, then, if there is soreness in the posterior limit of the maxillary denture, you have to relieve the pressure areas, rounding off the edges, adjust the preferred extension. If there is overextension, you can trim it down, make it into a normal extension. Okay. If you see over the alveolar ridge sore spots, the occlusion should be corrected by doing selective grinding. And if there are any acrylic blebs, removal of those acrylic blebs and polishing of the rough surfaces. Now, if you see under the lingual flange, that is when I said that centric occlusion does not coincide with centric relation, it can be remounted. The dentures can be remounted in centric relation, and then you can do selective grinding and correct that. Okay. Also, if it is seen under the labial flange, you have to reset the maxillary anterior teeth and train the patient to masticate in centric relation. Now, there are certain things. Now, all these other 4 points, these can be done by using the same denture. You don't have to remake the denture. But in case you have to reset the maxillary anterior teeth because to relieve the overbite, or you have to reduce the vertical dimension, you have to remake the dentures. See, reducing vertical dimension you can do to a certain extent by doing a little selective grinding, but that is not advisable. Okay, not advisable at all. But if it is really a minor correction to be done, okay, you can still do it. But the best way and the most accepted way would be to make a new denture. Okay. Next, after sore spots, we come to burning sensation. Now, when does a patient have burning sensation? It's when there is pressure over the anterior palatine foramen, or there is pressure over the mental foramen, or there is pressure over the posterior palatine foramen. Now, all these causes can be managed by relieving that area. If the area is pressing over, it will be absolutely fine. Now, if this burning sensation is because of other factors such as anxiety or vitamin deficiencies, a dose of vitamin B complex have to be given. We tell the denture wearers to stop wearing the denture for some time. Okay. Also, you can apply ice on the area which is burning, which will give you temporary relief. But you have to know the cause before doing the treatment. Okay. Next is redness. Now, if there is a fiery red appearance of the tissue which is seen over the denture base, the entire denture base area, as you can see in this photograph over here, okay, it is definitely not due to any sore spots or anything. You can definitely make out that there is some form of allergic reaction which is going on here. So it may be due to denture base allergy, which is extremely uncommon. Normally these kind of patients are very rare. You will never, at least till today, I have not come across anyone who has had a denture based allergy. Okay, so there are people, but very rare. Okay, so in that case, now what will you do if the denture based allergy is present in the patient? You will remake the denture with a different denture based material. Now, different denture based materials such as metals maybe. Now, so you have to do allergic test before doing it. Patient may be even allergic to metal. Then you use polyamides and other materials. Okay, so you have to know, because once the patient is sensitized to one kind of material, you have to see whether he is allergic to the other materials as well. Okay. Now, if there is a brief redness, not a fiery red, just a brief redness on the denture bearing tissues, it may be due to ill-fitting dentures or again due to vitamin deficiencies. So in that case, you will consider rebasing the denture to get the fit properly, or relining, or if it is due to any vitamin deficiencies, you will start them with vitamin therapy. The next thing is pain in TMJ. It is normally due to insufficient vertical dimension, or if the centric occlusion is not coinciding with centric relation, or because of trauma. Okay, the following you will do, like you will increase the vertical dimension, correct the occlusion by selective grinding, or give analgesics in the case of trauma. Okay, these are the corrective measures on the right hand side. Next complaint is tongue and cheek biting. Now, when do we see this? It is when there is insufficient horizontal overlap, or there is excessive horizontal overlap, that is overclosure. It can be also seen when there is changes in the plane of occlusion, when you do not set the plane how the previous, when the patient had his original teeth. If you do not replicate that plane of occlusion, normally this happens. If the posterior teeth are set too far buccal, that will cause your cheek biting. Okay, and if the posterior teeth are set too lingual, then it will cause your tongue biting. So it has to be set in the neutral zone. What do we say? That is, it should be the pressure from the tongue and the pressure from the cheek should be equal on either side. Therefore, it will cancel out, and therefore your teeth will be set in the most stable position. Loss of muscle tonus can also cause tongue and cheek biting because your cheeks become flaccid. Okay, so it falls back into the vestibule, so therefore there will be cheek biting. Normally doesn't happen to patients who have uh, been wearing dentures for long. Maybe if the patient has not been wearing dentures for many years and then they come for you for denture treatment, this is the um cause that you might think about. And also patients with epilepsy. Now, management of the tongue or cheek biting, you will increase the buccal overjet, restore vertical dimension. Now, all this has to be done by a new denture. You cannot do it in the old denture, okay? Recontouring the buccal surfaces, re-establish adequate tongue space by replacing your teeth in the neutral zone. And if there are any underextended or thinned out borders, you have to build up on those things, okay? Now we finished with complaints regarding comfort. Okay, complaints regarding comfort are done, in which we covered redness, sore spots, burning sensation, and clicking or pain in the TMJ. Now coming to complaints about function. Okay, so the first complaint regarding function would be looseness of the maxillary denture. Now why do we see this kind of complaint? It can be because the dentures are not occluding properly. Now why are they not occluding? That is because we have taken our impression with a displaced method, meaning if there are flabby tissues present and we displace these tissues while impression making using a mucocompressive technique, the denture or the base will rebound. So therefore the dentures will not occlude properly, which will cause looseness of the denture. Then if the underfilled buccal vestibule is present, dehydration of tissues, loss of posterior valve seal, that is your PPS is not properly recorded, okay, and overextension of denture borders and posterior extent. Okay, these are all the causes of the looseness of maxillary denture. Now how will we manage? You will improve the PPS area, you adjust the denture borders. For underextension, adjust it with autopolymerizing resin. So underextension you can add material, overextension you have to reduce material. Okay, surgical correction of the flabby tissues with reimpressions, and then you have to remake the dentures, and correction of flange thickness. Now, when the dentures are occluding in centric and still you have looseness of the denture. Now, the first point was when the dentures are not occluding at all and plus you have looseness. Now, this is when they are occluding but still you have looseness. It may be when the CR is not in harmony with the CO. If you have a hard a torus or a non-yielding hard area on the hard palate, incorrect tooth position, poor denture foundation, or malocclusion. Okay. Now, the management of this is you have to selectively adjust the occlusion. You have to provide sufficient relief and reset the teeth in correct position. Now, selectively adjust the occlusion and can be done on the previous denture as well. But in case you want to reset the teeth or provide reset the teeth in the correct position, you have to remake the denture. Okay. Relief also, you can trim the intaglio surface of the denture, under surface of the denture, and provide relief. But for resetting of the teeth, you cannot. You have to make a new denture. Now, looseness of the upper denture when incising food is done. Okay, this is, we are still on the upper denture, and the complaint is looseness. Okay, so when the patient has looseness when incising the food, what might be the reason? It might be due to loss of the PPS area, anterior teeth placed too labially, poor denture foundation, and improper incising habits. Now, the management for this would be you improve your PPS area, you reset your teeth in correct position. If in case the denture foundation is poor, you have to surgically correct it, or tissue massage, or some medication has to be given to correct the denture foundation. And the last point is improper incising habits, that you have to train the patient to masticate in centric. Okay, they cannot masticate in the front position or lateral positions. Now, looseness when yawning, opening wide, happens when the denture base is too thick in the buccal posterior area, which can be reduced by reducing the thickness of the denture base. And another point is denture overextended in the hamular notch area, which can be corrected by shortening the denture over this area. Okay. Now, looseness when talking is because of inadequate PPS area. You have to add the PPS area with autopolymerizing resin. Also, it can be due to overextension. In case of overextension, you have to adjust the PPS area, trim it basically. Coming to the next point is looseness of the mandibular denture. It could be due to the peripheral extension. You have to check the masseteric groove area, the lateral direction, especially in the external oblique ridge area, lingual flange or retromolar pad area. All these can be managed by adjusting the denture accordingly. Okay. Now, looseness can also be due to underextension of the peripheral seal, which can be corrected by adding. Placing the occlusal plane too high, you have to remake the denture in case this is the reason. Improper contour of the polished surface, recontour the polished surfaces. And because of a tense lower lip, also looseness can be present. Your mentalis muscle is very active. So we have to remake the denture with lower teeth set lingually with a labial concavity. Okay. Now, the third problem with respect to function is interference while swallowing. This can be due to too thick or overextended denture in the posterior region, or in the posterior lingual region for the mandibular denture. You can correct this by reducing the thickness and extension. Now, if there is insufficient or excessive VD, also swallowing can cause a problem. So you have to alter the VD accordingly. Alteration of vertical dimension cannot be done without remaking the denture. Okay, you have to remake it. Can be also due to incorrect tooth position, which can be corrected by resetting the teeth. Next point is clicking. Okay. Now, clicking is normally seen when there is excessive vertical dimension. Classic sign of clicking is when there is excessive vertical dimension. This can be corrected by reducing the vertical dimension. Now, they can also be clicking when there is poor retention and stability. What happens when there's retention and stability, poor retention and stability? The denture will keep falling down and will keep touching the lower denture. That's why you'll keep getting the clicking sound. Okay. If there is some cuspal interference, also you will get a clicking sound. So you have to eliminate any cuspal interferences. And also, giving an excessive incisal guidance can also cause clicking, which has to be corrected. Now, coming to the third category, that is complaints about aesthetics. Now, complaints regarding function, regarding comfort, to some extent can be corrected by means of trimming or adding or those kind of things. But if the patient complains about aesthetics of the denture, you have to 100% remake the denture. There is no way you can do any alteration on the denture to correct aesthetics. Okay. So, except one point is if you have a lot of labial fullness, and that is the point that the patient wants, that can be reduced. That's the only way. But if the teeth have to be moved, or the patient wants the teeth out, or the patient wants the teeth in, or the patient wants the teeth to have crowding or have gaps, or whatever it is, if they're not happy with the arrangement of the teeth and they are not happy with the aesthetics, it has to be remade the denture. Okay. So, the first complaint is fullness under the nose. The labial flange, the potential cause is that the labial flange is too thick or long. The management is to reduce or increase the extension of the flange. Now, depression of the philtrum, labial flange is too short or thin, you add material. If they complain that the upper lip is sunken, the maxillary anterior teeth are normally set to far lingually. You have to reset the anterior teeth. So if you have to reset anterior teeth, obviously you cannot do it without remaking. Okay. Too much of teeth exposed. This is seen in excessive VD, incisal plane too low, cuspids and lateral too prominent. In all these cases, you have to remake the denture with the correct whatever mistakes you had done. Next, if the patient complains about artificial look, now this can be due to the technique setup, basically the teeth setting of the denture. If the teeth are all of the same shade and they feel the teeth are too white or of the same shade, it looks like blocks of teeth, you know. Lack of grinding, incisal edges or angles, they want it to look more natural. Basically, the patient has high aesthetic demands. You have to gauge this at the first appointment itself. You cannot directly make the denture and then figure out that your patient wants all these things. You have to figure it out on the first day, the patient's expectations. That is the main thing. That's how you will never face this kind of problem where the patient is complaining of artificial look. Okay, so the way you can correct this is by giving characterization, choosing different shades, grinding the incisal edges, giving a little bit of discoloration, okay, giving a little bit of recession. It looks more of an elderly patient. It should not look like a Hollywood smile for an elderly patient. It looks very fake. So, but you have to ask the patient whether they require or they want these kind of effects to be given in their denture. The next category is complaints about phonetics. So, what if the patient complains there is a whistle kind of sound? It is due to a large space present in the anterior part of the palate. You have to reshape the anterior part. Okay. Basically, whistle sound is when there is too much space between the upper and lower anterior teeth. Okay. And lisp sound is exactly the opposite when there's too small space. Okay. So always remember, whistle is that you require air, right, for a whistle to occur. So there is a large gap between your lower teeth and your palatal area. So in the anterior part, if there is a lot of space, there's a lot of air which can pass, therefore a whistle sound comes. Now lisp sound is when there is too small space. Okay, so both these are because of the space between the teeth and your palatal region, or also because of the thickness of your anterior part of the palate, which again is going to cause a reduction or increase in the space. Okay. Now, indistinct th or t sound is due to inadequate interocclusal space, and the upper teeth, the setting of the upper anterior teeth is important for these pronunciations. Okay. Now, F and V sounds, it is due to the improper upper anterior teeth either vertically or horizontally, meaning upper, it is set to high, low, or inside or outside in layman terms. Okay, so the correction of this would be to reset the teeth accordingly so that the V and F sounds are corrected. So we are done with the post insertion problems of the patients. Okay, coming to the next part, that is relining and rebasing. Now, what is relining? It is a process of adding some material to the tissue side of a denture to fill the space between the tissue and the denture base. Okay, so rebasing. It is a process of replacing the entire denture base of the denture. Now, why do we have to reline and rebase? Okay, why? Because there are physiologic changes that take place in the jaws, in the upper and lower jaws. Inevitably, whether you wear dentures, you don't wear dentures, you give the best denture. You know, there is no interference, there is no ill-fitting denture base. You give the best denture. There will still be residual ridge resorption that is happening every year in the maxilla and the mandible. We had studied about this in, I think, my first or second lecture, that the mandible resorbs 4 times more than the maxilla. If you all remember, 1:4 ratio. Okay, so whatever you do, you make the best denture, the patient will still have some residual ridge resorption that occurs over the ages. So after maybe 5 to 6 years, or some patients 10 years, you know, who are wearing the denture, there will be some physiologic changes that occur, which will lead to loss of retention and stability. Because your bone is shrinking, your denture will remain there only. Denture will not adapt according to your shrinking tissues. Okay, so there will be a gap between your denture base and your shrinking tissues. That will result in loss of retention, stability, Therefore, it will lead to incorrect occlusal relationships, loss of vertical dimension. Okay, so all these things require us to refit our denture bases. Okay, so that's why we have to do relining and rebasing. Now, what are the reasons for relining basing? It is basically to improve the retention and stability of the denture, restore the vertical dimension of the patient, okay, give a better look or appearance of the patient, give better aesthetics, okay, relieve pain in some patients because of this retention and stability problem. There's a lot of sore spots which happen, a lot of redness, so there's a pain of the patient, and also give a even occlusal pressure. Once the retention and stability is catered to, you will have a even occlusal contact which happens. It will not move the denture bases. So in turn, you are providing good function and comfort to the patient. Okay. Now, what are the indications? Okay, it is adaptation, uh, poor adaptation due to resorption, looseness following a long-standing history of comfort, 3 to 6 months after construction of immediate dentures. Very important point to be noted. In cases of immediate dentures, which we will be discussing in my second part of today's lecture, uh, what happens is when you immediately extract your teeth and place dentures on the same day, there is no time for the tissue to heal, shrink. Okay, so this shrinkage and tissue healing will continue to happen over the first 3 to 6 months of denture wearing. Therefore, in immediate dentures, within 6 months to a year only, the denture starts becoming loose. Okay, because the maximum residual ridge resorption occurs in the first year after teeth removal. Okay, after you remove or you get a complete extraction, full mouth extraction done, in the first year itself, maximum residual ridge resorption occurs. Okay, so only in cases of immediate dentures, you will need to construct a new denture, or you can reline or rebase the old dentures. Okay. For geriatric patients, when new denture construction can cause physical or mental stress, patients who cannot afford a new denture, porous or discolored denture base, and where porcelain teeth are present, if you have to do, you have to do a rebasing. You cannot do relining. Okay. Coming to contraindications, if there is excessive ridge resorption, you have to remake the denture instead of relining. If there is presence of absolutely very severe abuse of tissue, if the patient has TMJ problems, a denture which has poor aesthetics and unsatisfactory jaw relationship. This is a most important point or a most important contraindication to relining and rebasing. If a denture has poor aesthetics and the jaw relations are not up to mark, you cannot reline or rebase this denture. You have to remake it. Okay. Denture with major speech problems or presence of severe osseous undercuts. Now, before relining or rebasing a denture, you cannot directly do it without doing some preparation for the tissues and for the denture. Okay. So first step is to prepare the tissues of the patient. Now, in case the patient has tissues like this, seen in the first photo here, like there is overextension and epulis fissuratum kind of structure which has grown away. There is overextension of this denture, I believe, over here. Therefore, it has caused growth of tissue over here. Now, you cannot reline and rebase immediately in these kind of tissues. Okay, you have to give it time to heal. Then only you can reconstruct your denture. So in these kind of cases, surgical removal has to be indicated, healing, and then you go ahead with your new denture. Okay. In case there is abused tissues, again, you have to give it time. Tell the patient not to use the denture for around 3 to 4 days. See how the denture base surface is. If it is relieved, it is back to normal, it is coral pink in color, you can continue the denture construction procedures. But in case you still feel that there is redness and all, give it another 3 to 4 days. So till the tissues come to normal, do not start your impressions. The last point would be to advise the patient for a regular massage of the gum tissue, okay, to keep it healthy before you're constructing your new dentures. Now, after you prepare the patient and prepare the tissues of the patient, you have to prepare your denture. That is the old denture, basically, which you're going to reline or rebase. Border extension is checked, undercuts are relieved, occlusal harmony is corrected, pressure points are adjusted, and you have to check whether an accurate posterior palatal seal is established. Okay. Now, what are the different types of resilient liners? They can be natural rubbers, vinyl copolymers, hydrophilic polymers, silicone-based compounds, acrylic-based compounds, or treatment liners, also called as soft conditioners or tissue conditioners. Mostly nowadays, only these two are used. Okay, that is acrylic and silicone-based. Okay, these are the older ones which are not used nowadays. Now, why soft liners should be used rather than rebasing an acrylic denture? Now, suppose there is an abused soft tissue which is there. Directly, rather than rebasing or relining, we would prefer to put a soft liner there, condition the tissues, okay? Now, why do we do this? Because a soft liner serves as a shock absorber, okay? There are two types of liners, that is short-term and long-term liners. The short-term liners are normally, the composition is of polymethyl or ethyl methacrylate. It is mixed with 60 to 80% plasticizer, that is dibutyl phthalate. Okay, important point to be noted. The composition also has to be known, okay, of all these things. And in case of long-term liners, you have heat-activated liners, okay, or silicone-based compounds. Now, what are the disadvantages or limitations in using these soft liners? It reduces the denture-based strength. It causes loss of softness or resilience, means you cannot use it for a long duration. The maximum time you can use a soft liner is for 7 days. You have to replace it after 7 days. Okay. It causes colonization of Candida albicans if it is not replaced in time. There is difficulty in keeping soft liners clean because these are very softish, soft material. So if you keep on rubbing it with a brush, what happens is that they peel off. So we have to be very careful while keeping these dentures clean. There can be dimensional instability that occurs, failure of adhesion, difficulty in finishing and polishing, and also change in color. Now, there are a few procedures of relining which I have broadly divided here. There is a classification which can be divided into clinical procedures or laboratory procedures. Okay. In clinical, there are three types, that is static, functional, or chairside. In static, you can do a closed mouth technique or an open mouth technique. Now, in the procedures which are done in the laboratory, there is articulator method, jig method, or flask method. Now, in most of the multiple choice questions which I have gone through and I've seen, most of them do not ask a lot of details regarding each of these methods. So I'm not going into details, but if you all are interested to know what is what, you all can comment down and let me know if you all need to know any one particular technique or you want me to discuss all of them. If you all are not able to understand, and go and read it in any standard textbook. It is very well explained, and it is very practical and logical. You don't have to put much of brains basically to understand these procedures. So, but still, if still any of you all have doubts, no problem. Please ask whatever questions you'll have to ask, and you can comment down below. Okay. So let's move on to today's MCQs. So the first MCQ for today is how much powder, just a minute. Yeah. How much powder liquid ratio is used in acrylic resin for denture fabrication? Okay. This was among my first slides, I think. Powder to liquid. Okay. So powder to liquid is 3:1. So the answer to this question is 3:1. That is 1B. Okay. The answer to question number 1 is B, 3:1. Question number 2, which of the following material is most commonly used in the fabrication of complete denture? Nylon, heat cure acrylic resins, cold cure, or fluid resins? Very easy question. The answer to this is B, that is heat cure acrylic resins. Okay. The compressive force applied during packing the acrylic resin dough should be applied rapidly, all of a sudden, slowly, or none of the above. It should never be applied rapidly. It causes a lot of porosities, and same thing, all of a sudden is almost same as rapidly. So no, both are no-nos. So the answer to this is slowly. It has to be applied slowly so that the flash comes out intermittently and slowly, so that there's uniform pressure which is being applied. Okay, if you apply rapid pressure, one area might have more pressure than the other. So it's better to do it slowly. The answer to question number 3 is C, slowly. The excess amount of resin dough which comes out of the flask during packing is called as corrosion, flash, slash, none of the above. The answer to question number 4 is B, flash. Before curing cycle begins, ideally the properly packed flash should be allowed to stand for 5 to 10 minutes, 10 to 15 minutes, 15 to 20 minutes, or 30 to 60 minutes. Okay, the answer to this is 30 to 60 minutes. So before the curing cycle begins, we keep the flask for something called as bench curing. Okay, bench curing, curing, bench curing it is called. So ideally speaking, at least for 30 minutes you need to keep your flasks outside before putting it in the water bath for 30 minutes minimum. So the answer to this would be 30 to 60 minutes. Okay, that is 5D. Question number 6, the specified curing cycle temperature and time is A, 165 Fahrenheit for 9 hours, or 165 Fahrenheit for 90 minutes followed by 30 minutes at boil. C, both of the above, none of the above. So both these are correct. As I told you, they can ask you in degree Fahrenheit, or they can ask you in degree Celsius. So in this question, they have asked in degree Fahrenheit. Okay. Question number 7 is above. Question number 6, C. Which of the following are advantages of cold cure acrylic resin over heat cure acrylic resin? Advantages of cold cure over heat cure: slightly improved dimensional stability, reduced processing time, less brittle. D, all of the above. So all of these are advantages of cold cure actually. Okay, all of them. So the answer to question number 7 is D, all of the above. Okay, question to answer number 7 is D, all of the above. Question number 8, food lodgement beneath the prosthesis is due to A, deflective occlusal contact, increased flange length, decreased flange length, or increase in BD. So it is not due to deflective occlusal contact. It is not due to increased flange length. Definitely it is due to decreased flange length, because if there is a decreased flange length, obviously food is going to go and get stuck between the denture and the tissues. So the answer to question number 8 is C, decrease in flange length. On recall visit of a CD patient, he complains of sharp pain on the edentulous ridge. On examination, there is a clean white area on the ridge. Clean white area on the ridge. The treatment is roughen the corresponding area of the denture, smoothen the acrylic nodule of the denture, apply tissue conditioner, or adjust occlusion. So mostly if he complains of a sharp pain and there is a clean white area on the ridge, it is a sore spot. Okay, it is a sore spot. So what will you do? You will smoothen the acrylic nodule on the denture. Okay, you will smoothen the acrylic nodule on the denture. That is 9B. Question number 10, the soreness of underlying tissues may result from unbalanced occlusion, uneven distribution of occlusal surfaces, high pressure of the answer to question number 10, all of not sore dentures. It can be due to too long posterior palatal seal, too deep. Yes, it can be due to both these, posterior lingual flange because of this as well. So the answer is D, all of the above. 11, the answer is D, all of the above. Question number 12, defective speech with complete dentures may result from deficient palatal contour, excessive opening or vertical dimension, incorrect arch form, or D, all of the above. The answer to this is again D, all of the above. Okay, defective speech with complete dentures may result from a deficient palatal contour. It can be due to excessive VD. It can be also due to incorrect arch form. So question number 12 is D. Clicking of teeth in complete dentures may occur due to excessive vertical dimension, poor retention of mandibular denture, unbalanced occlusion, or all of the above. Again, the answer to this is all of the above. So most of these questions I have put forward in such a way that you will at least revise your causes. Okay, in these questions, you will at least revise your causes while reading these questions. That's why most of these answers are all of the above. It is just for you to revise all of the causes. So at least doing MCQs, you will recall everything. Okay. Question number 14. Which of the following is or are causes of the denture looseness? Inadequate occlusion, poor adaptation of bases, lack of posterior palatal seal, or all of the above? The answer to this is again all of the above. Okay, all of the above. Question number 15. Inability to eat with complete dentures may result from excessive vertical dimension, insufficient vertical dimension, incorrect centric relation record, or all of the above. All these cause inability to eat because they cause discomfort. Excessive vertical dimension will cause clicking. It will cause a difficulty in eating. Okay, insufficient will also cause the same thing. Incorrect centric record will also cause unstable dentures. So all of them will cause inability to eat. Therefore, 15, the answer is D. 15, the answer is D, all of the above. Question number 16. The forward shifting of mandibular denture base from excessive loading from posterior occlusion results in tissue ulceration in forward shifting of mandibular denture base from excessive loading of posterior occlusion. It will cause ulceration in. Just imagine this happening. Forward shifting of the mandibular denture base from posterior occlusion. So definitely where it will go and stop? In the anterior part, right? Anterior lingual part. Okay. So the answer to question number 16 is D. Question number 16 is D. Anterior lingual flange. The tissue irritation and ulceration in mandibular posterior lingual flange area occurs due to opposite side imbalanced occlusion, tissue surface irritant, loose tissue entrapment, or all of the above. Ulceration in mandibular posterior lingual flange. That is all of the above. Question number 17 is all of the above. The lesion posterior to hamular notch is usually caused due to posterior to hamular notch. Okay, short denture borders, long denture borders, posterior denture border extending up to maxillary tuberosity, and all of the above. It is definitely not short denture borders. Okay, posterior denture border extending up to maxillary tuberosity is a correct thing. You have to extend it till the maxillary tuberosity, so it cannot cause a lesion. So it's not this. So the answer to question number 18 is B, that is long denture borders. Question number 18, B, long denture borders. Okay, that will cause a lesion. Excessive pressure from the mandibular buccal flange in the region of mental foramen may cause tingling sensation. Mental foramen. Okay, mental foramen normally gives out your mental nerves and vessels. The mental nerves and vessels, they innervate which areas you need to know. You need to recall your anatomy in this question. It's a kind of an application question. So mental foramen will supply your lower lip area, your chin area. So let's go and see the options. That is upper lip, no, definitely not. Cheek, they have not mentioned which cheek, so not definitely not. Lower lip, yes. Okay. Tip of the tongue, no. The mental foramen does not innervate that, so it will not be tip of the tongue. So the answer is 19C, that is lower lip. Okay, lower lip. Question number 20. The excessive pressure on the incisive papilla may cause numbness in. Excessive pressure on incisive papilla. Again, you have to know what comes out in this area, like from the incisive foramen, your incisive nerve and vessels come out. So what area do they innervate? You need to know all this. Again, applied anatomy. So let's go to the options. Anterior part of the hard palate, posterior part of the hard palate, soft palate, all of the above. So the answer to this is anterior part of the hard palate, because posterior it is the greater palatine which innervates. Okay, so the answer to question number 20 is A. Question number 20 is A, anterior part of the hard palate. Question number 20, A. Question number 21. Gagging may be caused by A. Overextended maxillary posterior border, underextended maxillary posterior border, inadequate posterior palatal seal, or all of the above. It can be caused by all of this. So the question number 21, the answer is D. Question number 21, answer D. Looseness of maxillary denture and opening mouth wide is caused by thin looseness of maxillary denture. Okay, when opening mouth wide. Okay, so A, thin distobuccal flange of the maxillary denture, thin thin distolingual flange of the maxillary denture, thick distobuccal flange of the maxillary denture, or thick distolingual flange of the maxillary denture. It's definitely opening mouth wide. It's definitely the distobuccal area. Okay, it's definitely the distobuccal area, and looseness will not be because of thin. It will always be because of a thick distobuccal flange. The answer to question number 22 is C, thick distobuccal flange of the maxillary denture. The loosening of the maxillary denture during smiling is caused by excessive thickness of maxillary denture in the region of buccal notch, excessive height of the maxillary denture in the region of buccal notch, excessive thickness of the maxillary denture distal to buccal notch. So all these can be the reasons for loosening. So the answer to question number 23 is all of the above. The generalized soreness of basal seat may be caused by excessive vertical dimension, nutritional or hormonal problems, unhygienic dentures, or all of the above. The answer to this is also all of the above. Question number 24D. After insertion of lower denture, it gets lifted during tongue movements. After insertion of lower denture, it gets lifted during tongue movements. It is due to overextension in anterior lingual, overextension in posterior lingual, overextension in retromolar pad, and overextension in buccal flange. Okay, it's either this or this. So the answer to this is A, overextension in anterior lingual flange, because it gets lifted during tongue movements. Okay, now you might say even posterior lingual flange, it does get lifted during tongue movements. They have not actually specified what tongue movements, whether it's protruded or lateral, rolling the tongue back. They have not mentioned anything. So the most appropriate answer in this would be overextension of anterior lingual flange. Okay, so that's why 25, the answer is A. Excessive overjet can cause overjet is a horizontal overlap. Okay, not vertical is overbite, overjet is horizontal overlap. So excessive overjet can cause difficulty in pronouncing K, difficulty with all sounds, both of the above, or difficulty with S sounds. So any problem with your anterior teeth, overjet, overbite, anterior is placed too lingual, too buccal, too above, too below, any anterior teeth placement issues will give you problems with your sibilant sounds, that is S sounds. Okay, S sounds, the F and V sounds. Okay, and it can also give you a problem with ch sounds. Okay, so all these sounds will get affected. So right now over here in the options we have S sound, so the answer would be D, 26D, difficulty with S sounds. 26D. Which of the following material you will not advise is the denture-based material? Polymethyl methacrylate soft liner, polymethyl methacrylate base metal alloy, or flexible denture-based material? So you have to read very carefully, okay, the options over here. Over here they have written PMMA soft liner, and the question is which of the following material you will not advise as a denture base material. Okay, don't get confused. Soft liners are applied on the denture base, they are not totally the denture base material. Okay, so the answer for 27 is A, PMMA soft liner, because all these others are used as proper denture based materials, but soft liners are applied onto other denture based materials. They are not itself the denture base, right? Okay, so 27A, PMMA soft liner. A CD wearer reports to the dentist with symptoms of TMJ pain, discomfort, and clicking sound. Intraoral examination would increase vertical dimension. You can see your TMJ pain, even decreased, but mostly in cases of increase. So we will mark the option as C, that is decreased interocclusal space. That is basically because of increased vertical dimension, you have decreased interocclusal space. Okay, so 28, the answer is C. 28, the answer is C. Acrylics used as denture base has all of the advantages except bonds to acrylic teeth is an advantage, ease of repair is an advantage, ease of relining is an advantage, insulates underlying tissue form thermal changes. No, it doesn't insulate. Okay, it does not insulate. So that is it insulates, that it acrylic insulates, but it is not an advantage. Okay, we want the temperature of the food to be appreciated by the patient. It will be more the food, the taste, the food, enjoyability of the food eating will be more if you feel the temperature of the food, whether it's hot, it's cold. So insulating the underlying tissue is not an advantage. So we mark option D. Question number 29, option D. Cheek biting in dentures is caused by increased occlusal vertical dimension, steep corpus angle in posterior, decreased pad coverage, or reduced horizontal overlap of posteriors. Question number 30, the answer is D, reduced horizontal overlap of posteriors. Okay. Question number 31, an edentulous patient has complained that his denture becomes loose several hours after wearing. This indicates several hours after wearing. So you've given the patient the denture, and after several hours of wearing, he says that it is loose. Okay. So what is the reason? While inserting the denture, you might have checked all the extensions, everything. Okay. So it is unlikely that it is due to the extensions of the denture base or due to PPS, because that would be evident when you're giving the denture. And he has had looseness in a few hours. So mostly the patient has tried to eat something and then has had looseness. So you have to think in this way. Okay. Application basically. So an improper extension denture base, no, I don't think so. Deflective on occlusal contacts, maybe. A high vertical dimension, maybe. An overextended denture flange, not really, because you would check all this. Okay. So the answer to this question number 31 is B, that is deflective occlusal contacts. Whenever the patient complains of looseness within a few hours or on the day of insertion, any question comes like this, it's always the answer is deflective occlusion contacts. It's because the patient has tried to close or try to chew something that is called looseness, that has caused looseness. Okay. So the answer to question number 31 is B, that is deflective occlusal contacts. A patient straining to bring his lips together after wearing a complete denture indicates increased vertical dimension, decreased vertical dimension, increased freeway space, or limbally precentrals. It is increased vertical dimension. 32A. The upper denture falls when patient open mouth wide due to thick labial flange, overextended borders, thick distobuccal flange, or poor peripheral seal. When the patient opens wide, it's definitely the buccal frenum that is acting. So thick distobuccal flange is the answer. 33, the answer is C, thick distobuccal flange. Okay, 33C, thick distobuccal flange. With denture soreness and irritation on the slopes of the crest of the ridge, it is usually caused by error in occlusion, pressure spot impression, both of the above, none of the above. The answer to 34 is C, both of the above. Relining is done to correct base tissue relations, correct occlusion, provide retention following denture failure due to porosity. So relining, okay, relining. It is not to correct occlusion. Yeah, you can do it to correct occlusion as well, also to provide retention, but the main all these actually are partially correct. Okay, but the main reason why you're doing relining is to correct base tissue relationship. Okay, that is the main reason you're doing it. So the most appropriate close answer would be A, 35A, which doesn't mean that it doesn't correct occlusion or provide retention, or uh, due to denture failure also sometimes relining rebasing is done. So it doesn't mean that these other three options in the other three options relining does not help, but the most appropriate is option number A, that is correct the base tissue relationship. So we will be marking option A, 35A. As compared to relining, rebasing of a denture, a change is effect in centric occlusion, centric relation, entire denture base, or tissue surface. So as compared to relining, what is the difference in rebasing is the question. So therefore the answer is C, entire denture base is changed. In relining, only a layer of the denture base is changed, like maybe 1 or 2 mm is trimmed and you reline the denture. But in the base, the entire base, except the teeth, are kept, and entire base is changed. Okay, so 36, answer is C. Tissue conditioning materials is indicated when tissue symptoms are related to diabetes. Mucosa is inflamed due to ill-fitting dentures. Mandibular tori is present. Maxillary tori is present. So the answer to question number 37 is B. 37B. Major drawback with silicone liners. The answer to question number 38 is B. Inability to bond to acrylic denture base. The most commonly used material as soft liners include plasticide acrylic, silicone rubbers, fluoropolymers, both A and B. Most commonly used are the first two. That is the answer to question number 39 is D. plasticized acrylics and silicone rubber. So D, 39D. Minimum thickness required for use of tissue conditioners. Minimum thickness is 1 mm. So the answer is here D, 40D. Question number 41. Powder liquid ratio of tissue conditioner is 1.5 upon 1, 1.75 upon 1, 2 upon 1, or 1.25 upon 1. The answer to question number 41 is D. Question number 41 is D. Powder liquid ratio is 1.25 is to 1. Okay, 1.25 is to 1. An overly thick palatal denture base will primarily affect the stability of the denture, affect aesthetics and retention, or affect phonetics. Okay, overly thick palatal denture base will obviously affect phonetics. Okay, your tongue will not be very comfortable with the new feel of the thick palatal denture base, so it will affect phonetics. 42, the answer is D. 42, the answer is D. Question number 43. If lingual extension is too deep, the patient will have difficulties in lingual extension too deep. Protrusion of tongue, movement of soft palate, rolling of the tongue back and forth, or movement of tongue in the lateral direction. Question number 43, the answer is D. Contraindications of relining and basing is when denture is with poor aesthetics, TMJ problems, unsatisfactory GR. Answer to question number 44 is all of the above. All of the above. Plasticizer used in soft liners are tertiary amine, dibutyl phthalate, benzoyl peroxide, or none of the above. The answer to this is dibutyl phthalate. 45, the answer is B. The process of replacing the entire base of the denture is called as rebasing. Entire base, that is rebasing. 46B. Patient has difficulty in swallowing a CD wearer. The most probable cause is increased VD, decreased VD, decrease in retention or thickness. Difficulty swallowing is always seen in increased vertical dimension. Okay, difficulty in swallowing is always seen in increased vertical dimension. So 47, the answer is A. A complete denture patient complains that he has pain in his throat during swallowing. This indicates, see again swallowing. There are two questions here. I've purposely put it together. Okay. Patient has difficulty in swallowing, but you have to see the options. Okay. Here, increased VD, decreased VD, decreased retention and thickness. So none of these will cause swallowing issues. Only increased VD. In this question, a complete denture patient that has pain in his throat during swallowing. This indicates overextended PPS, overextended lingual flange in the retromyloid region, okay, or his tonsils are inflamed. So actually, an overextended PPS also can cause swallowing issues, and overextended lingual flange also. But here the the option number 3 is more specified. Overextended lingual flange in the retromylohyoid region. This is one of the main reasons also why you can get swallowing issues. So overextended lingual flange in retromyloid is the most appropriate answer. Okay, 48C. Question number 49. Patient complains of looseness of dentures within 2 hours of insertion. The most likely cause is psychological, adaptive response, deflective occlusion, unretentive denture. I told you, if the patient complains of looseness within a few hours or on the same day, it's always deflective occlusion. So 49, the answer is C. Question number 50. A patient complains of generalized soreness over the entire mandibular ridge. This is probably due to occlusal imbalance, excessive vertical dimension, overextended borders, or underextended border. Question number 50. Generalized soreness is always due to excessive vertical dimension. It also can be due to overextended borders. Okay, both these can cause generalized soreness actually, but the most appropriate or most common or most close answer to the question is option B, that is excessive vertical dimension. So we finish with the first 50 MCQs for today. That is part 7, complete denture part 7. We will be going to the next part, that is part 8. Let's just open that slide. I will proceed towards the next PPT now. So proceeding to the next part for today, that is complete denture part 8, and this is the last section of complete denture. Okay, the last section. It's a very small part, so we'll complete the discussion quickly. Okay, but we have a few revision MCQs at the end of the session also for today. Okay, so let's proceed with the last part, that is the unconventional complete dentures. Now, why do we need unconventional complete dentures? Why can't we just do with the normal conventional types? So, when conventional complete denture does not suit the patient's needs, certain modifications are made to meet the patient's requirements or needs. Such dentures can be termed as special or unconventional complete dentures. So we will be discussing three special complete dentures or unconventional complete dentures today. That is single complete denture, immediate dentures, or over dentures. Okay, there are many more unconventional complete dentures, but these are the three main ones which are important for you all. Okay, coming to the first one, that is single complete denture. It is a complete denture that occludes against some or all natural teeth, a fixed restoration, or a previously constructed RPD or CD. Okay, so basically a complete denture versus your natural dentition, another denture versus another lower denture, or a removable partial denture. So when is it indicated? It's indicated when a complete denture, that is a edentulous upper or the lower, is opposing natural teeth sufficient in number not to necessitate a fixed or removable partial denture. It can be opposing a partially edentulous arch in which the missing teeth can be replaced by FPD, a partially edentulous arch in which the missing teeth have been or will be replaced by an RPD, or it can also be an old existing complete denture. Okay. Now, what are the disadvantages? There is extensive morphological changes in the denture foundation. When natural teeth oppose a complete denture, there is a lot of pressure from the natural teeth which falls on the artificial dentition. Therefore, it causes morphological changes. You will see a lot of flabby tissue, a lot of ridge resorption, which is replaced by flabby tissue. Okay, if the natural teeth, the forces are too much. Jaw relationship extremes which make it difficult to arrange artificial teeth for a denture. Now, sometimes what has happened is the patient is edentulous for a longer period of time. So all the lower teeth have supra-erupted, or they are supra-erupted in various extremes, you know. So the occlusal plane is totally disrupted. It's very difficult to arrange the upper complete denture teeth because of the lower teeth. So that's what they mean by this point. The last point is excessively displaceable denture bearing tissue, that is flappy ridges. Now, the most common scenario of a complete denture versus RPD is a combination syndrome. It is when a complete denture is opposing, upper complete denture is opposing a lower mandibular distal extension RPD. Okay, when a upper complete denture is opposing when an upper complete denture is opposing a lower partial denture, okay, and only the anterior teeth are present. Okay, it was basically described by Ellsworth Kelly in 1972. Now, the main clinical features which are seen in combination syndrome is that there is uh, bone resorption in the anterior maxillary region. There is papillary hyperplasia and downgrowth of the maxillary tuberosities, which in turn causes, because the occlusal plane is lowered over here, it will cause excessive force on the mandibular ridge here. Therefore, this is going to cause mandibular bone resorption posteriorly. And also because this occlusal plane is now tilted, these lower anterior teeth will keep on supra-erupting to touch the upper denture. So therefore, this is the whole vicious cycle which occurs. Okay, these are the 5 clinical features which were given. Now, Saunders et al. Added another few clinical features to those 5. He says that there is a loss of vertical dimension of occlusion, there is occlusal plane discrepancy, there is anterior repositioning of the mandible, epilus fissuratum, and adverse periodontal changes. Okay, so all these clinical features have to be memorized. You have to learn. If you learn it in the form of this diagram, you will remember it always. You will never forget it. Okay. Next, coming to immediate dentures, any removable dental prosthesis fabricated for dental placement immediately following the removal of natural teeth or tooth. Okay, so on the same day of extraction, you will give the complete denture or immediate denture. That is called as immediate complete denture. Okay. Now, what is the requirements? Complete compatibility with surrounding oral environment, restoration of masticatory efficiency within limits, harmony with the functions of speech, respiration, and deglutition, aesthetic acceptability, and preservation of remaining tissues. Now, the indications of a immediate complete denture would be a dentulous patient or a partially dentulous patient whose remaining natural teeth are indicated for extraction. Okay, patients for whom complete extractions are required, but aesthetics cannot be compromised. So sometimes patients have all the posteriors which are already extracted, only anteriors are remaining, and they just do not want to extract these anteriors because they do not want to look edentulous. So in these kind of cases, when the patient has high aesthetic demands, you can advise for an immediate complete denture. Okay. The contraindications for these are if the patient undergoes radiation therapy, if there are systemic conditions which affect the bleeding time, clotting time, aged patients, medically compromised patients, if there is a large abscess or cyst with respect to any of the teeth which are present for extraction, any psychological disorders, or any patient who cannot come for multiple appointments. So, a brief overview of the fabrication of an immediate complete denture. First step, that the teeth are extracted with minimum trauma. A clear acrylic guide is checked for is used to check for impingement. Okay, all the bony prominences, bony sharp margins are rounded by using this clear acrylic guide. After completion of the surgical procedure, denture insertion is done and denture is checked for overextension. And then final corrections are done in recall visits. A tissue conditioner can also be used to give good retention if the adaptation is poor. Okay. The advantages are it maintains patient's appearance. It acts as a bandage or a splint to control the bleeding. The face height, the muscle tone, vertical dimension, everything is maintained because you've just extracted the teeth and put the complete denture. So there's no period of edentulessness as such for the changes to occur. Nutrition is maintained. Adjustment to new dentures is quicker. There is no psychological or professional state which is hampered. The artificial teeth can be arranged to occupy the exact same position as the natural teeth because you know where the natural teeth are present now. Your patient has not come to you already with extractions done. He has come to you before extraction. So you will know where the natural teeth are present. So it will help you to arrange his artificial denture teeth also. Lesser resorption, so bridges are better adapted to support the denture. Disadvantages are that anterior trine is not possible, bone resorption and shrinkage occurs, so frequent relining is required. There can be an anterior ridge undercut, temporary impairment of speech and mastication. These temporary impairment of speech and mastication is not only with immediate complete denture, it's with any complete denture. Okay, so this is just one of the disadvantages. It requires more chairside time and appointments. Now, this is a very important slide. Okay. Now, after giving your immediate complete denture, what is the post-insertion care which have to be catered to? So first, when the denture is given, for the next 1 week, the patient has to wear the denture at night. After the patient wears the denture of night on the first day, after 24 hours, the patient has to come to the clinic for a dental visit to check for any sore spots or any discomfort. The denture is removed and cleaned and checked for overextensions or pressure spots. Then again, after 1 week, the patient is seen and again occlusal correction is done. Then a tissue conditioner is replaced for every week and is recalled for at least 4 weeks or a month, a period of 1 month. You can keep doing your occlusal corrections within these visits, okay, checking the denture base area. And it actually takes 8 to 12 months for complete healing of all the extraction sockets, okay. You have to reline the denture after 6 months. All these points have to be noted, okay. Each of them have been asked in multiple choice questions. So please do not forget to go over these points. Over dentures. Any removable dental prosthesis that covers and rests on one or more remaining teeth and or dental implants is also called as an overlay denture. It is also called as an overlay denture. Now, overdentures can be classified based on the application of the complete overdentures. It can be a transitional overdenture, immediate replacement overdenture, or a definitive overdenture. It can be based on the type of support. Okay, it can be a tooth or root supported overdenture or an implant supported overdenture. Based on the preparation of the abutment, it can be a non-coping overdenture or a coping overdenture. Based on the type of attachments which are used, it can be a stud retained overdenture, bar and clip retained overdenture, magnet retained overdenture, or locators. Now, what are the requirements for your overdentures? You have to have a good healthy underlying tooth. Healthy underlying tooth, what I mean to say is, you mostly when complete extraction is indicated, some one or two teeth will be there which have 50% bone loss, and you do not know whether to extract these teeth, no, keep it, because the tooth is not mobile also. So these kind of teeth are excellent abutments for overdentures. Okay, so you have to check the periodontal status of the tooth. Okay, I'm not saying it will have 100% periodontal status, or it will be the best periodontal status, but at least 50% of bone has to be 30 to 50% of bone have to be present. Then only we are going to take that as a abutment for overdenture. Now, the crown root ratio is reduced, okay, because those tooth go below your complete denture. Okay, so the after reduction of the crown root ratio, whether it will be favorable for the acceptance of your complete denture has to be checked. The basal seed tissue has to be checked. There should be simplicity of construction. Okay, ease of manipulation. The overdenture should not cause discomfort while insertion and removal for the patient. They should not be struggling with inserting it on these stud or bar retained overdentures. Okay, it should be easy. There should be harmonious occlusion that can be given, aesthetics, and also lastly, it must fulfill all the requirements of a normal complete denture. Then only we can go ahead with maintaining these abutments for overdenture. Now, what is the advantage of overdentures? It preserves alveolar bones since we are retaining some teeth in the jaw. Preservation of proprioception, retention, and support. It's a simple approach for some patients which you might expect very reduced retention or stability. Maintaining these teeth really uh, cause a big benefit to the patients. Periodontal maintenance. Convertibility. If any of the abutment needs to be extracted in the future, it can be relined and rebased into a conventional denture. Okay, you don't need to remake the entire denture. You can reline that area with your cold clay acrylic and you're good to go. Cost. When weighing the total surface involved, cost effectiveness is much more as compared to conventional CD. And harmony of the arch form. Now, disadvantage is that since you're retaining a tooth below the denture, patient should have very good oral hygiene and should maintain it very well, or there will be caries susceptibility. The periodontal status will further deteriorate. So that has to be maintained. If your patient does not have good oral hygiene, does not have dexterity to maintain it, then it is a complete no-no. Okay. If there are bony undercuts, encroachment of interclusal space, aesthetics, if you expect periodontal breakdown, then these are all the disadvantages. Okay. Now, what are the indications? If there are few remaining teeth which can be used as very good abutments for your overdentures, in case of severe loss of periodontal attachment, so we are trying to save the not poor, I would say fair prognosis, or nearing poor prognosis kind of teeth. If there is a CD opposing mandibular natural teeth, conditions where retention is difficult to obtain with CD, such as xerostomia, poor residual ridge, any congenital deformities, or partial loss of the maxilla or mandible. In cases of cancer patients who get resections of the maxilla mandible done, this option is very good. Now, contraindications are patients who cannot maintain these abutment teeth. As I said, if the patient is not able to maintain oral hygiene, doesn't have enough dexterity, especially patients who have Parkinson's disease or disabled patients. So these kind of patients, you cannot give overdentures because it will be very difficult to maintain. In cases where there is reduced interclusal space, any bony undercuts or abutments are unsuitable for endodontic or periodontal treatment. Now, coming to today's MCQs, the second part. So, we finished with the first 50 MCQs in the first part of today's lecture. Let's proceed with question number 51. A patient with class 3 mobility, just a minute. A patient with class 3 mobility of upper and lower teeth is suggested immediate complete dentures. When both maxillary and mandibular immediate complete dentures are proposed, then what is the recommended protocol? Patient with class 3 mobility of upper and lower teeth suggested immediate complete dentures. Okay. Option A, they should be both constructed together. Option B, make maxillary first followed by mandibular. Construct mandibular first, or immediate dentures should not be made only. So the answer to question number 51 is A, they should always be constructed together. While selecting overdenture abutment, preference is given to posterior abutments, anterior abutments. There is no reason for any preference, submerged roots. The answer to question number 52 is anterior abutments. Now, why? Everyone says that posterior teeth have more surface area. They are more, capable of taking load and all this. And why, in cases of overdentures, we want anterior abutments? Now, there are two reasons. One reason is single-rooted teeth are less susceptible to uh, caries or periodontal disease as compared to multi-rooted tooth. Okay, so there is a furcation there. There's more area for the infection to occur, and it's difficult to maintain posterior teeth because sometimes brushing is difficult. So patients ignore whatever cannot be seen. At least anterior teeth, they can be seen, so they maintain it. So that is why anterior abutments are selected. Another very important reason is whenever we open our mouth, it's in a crocodile fashion. The space between the upper and lower jaw in the posterior region is always lesser than the anterior region. It opens in the form of a crocodile. Okay, so whenever we talk about overdentures, we need very specific interocclusal space. Okay, and when we are maintaining a tooth, we have to have the tooth, then we have to have the attachment, and over that we are going to be giving a complete denture. So we require so much of space. In the anterior region, we get more space. In the posterior region, if we maintain a tooth and give the denture will become very thin in that area. Therefore, it can be susceptible to fracture. So interocclusal space is less in the posterior regions. That is also another major reason why overdenture abutments are selected primarily in the anterior region. Now, if your patient has very good interocclusal space and you're confident that you are going to get a good thickness of the denture in even after keeping a posterior abutment, definitely you can go ahead and keep it, but it's most of the time, most 90% of the times, it is not the case. So therefore, question number 52, the answer is A, anterior abutments. Question number 53, patient is seen with all maxillary teeth removed and lower arc is intact. However, the lower molars are supraerupted so that occlusion plane is not level. What should be done in such a case? Okay. The occlusal plane of the natural teeth must be made level. The artificial teeth must be set to contact only highest parts of the natural teeth. Onlays are given to shape and alter the height of the teeth. So in this kind of case, all these three should be done. So the answer to question number 53 is D, all of the above. A patient is observed with complete loss of teeth in maxillary arch and loss of the molars on both sides of the lower arch. What is the treatment option for this clinical scenario? Only maxillary denture should be made. Extract the lower teeth. Lower denture may or may not be made. Construct both upper and lower denture. Now they are saying there is loss of teeth in the upper and lower. So definitely both have to be constructed. So 54, the answer is D. Both upper and lower denture have to be constructed. What is the characteristic of traditional immediate complete denture? The denture can be realigned once healing is complete. The denture can be placed in the mouth after healing is complete. Denture is temporary and replaced after healing is complete. The denture can be kept as a long-term prosthesis. A traditional immediate complete denture, it can be relined once healing is complete, placed in the mouth. So it is basically temporary and is replaced after healing is complete. So the answer to question number 55 is C. Question number 55 is C. In the treatment plan of a conventional immediate complete denture, the anterior teeth are extracted. Question number 56, the answer is D, after making the immediate denture. After making the immediate denture. On examination of a patient in maxillary arch, the posterior teeth and lateral incisors on both sides are missing. Posterior teeth and lateral incisors. That means only the canines are present and healthy. You would like to extract the canines and centrals also are present because they said only laterals are missing. So the options are extract remaining central incisors and go for an overdenture on canines, cantilever bridge for posterior and RPD for lateral. Any of the above, none of the above. The answer to this is A, 57A. Immediate dentures must not be removed for the first 24 hours. I had mentioned this. 58, the answer is C. Jiffy dentures is a type of interim immediate denture, fixed partial denture, conventional CD or cast partial denture. Jiffy dentures are also called as, for immediate interim dentures, you call them Jiffy dentures. Okay, so the answer for 59 is A, immediate denture. The advantages of immediate dentures over conventional dentures include protection of the surgical site, maintenance of vertical dimension, avoidance of embarrassing lengthy edentulous period, or all of the above. The answer to question 60 is all of the above. All of the above. Anterior trine is not done in which of the following situation? Immediate complete denture, conventional complete denture, both of the above or none of the above. Anterior trine is never done in immediate complete denture. Okay, conventional complete denture we do anterior and posterior trine. That is definitely a step to be done, cannot be avoided. But in case of immediate complete denture, what happens is we are extracting the teeth and placing the complete denture on the same day. So how can we do the anterior trine, right? So therefore, the answer to question number 61 is A, immediate complete denture. What adjustments are required when an immediate denture is inserted? Surgical removal of bony undercuts to allow seating of the denture, reducing the fullness of the labial flange, relining, or adjusting. So the answer to question number 62 is A, surgical removal of bony undercuts to allow seating of the denture. Which of the following is the best overdenture abutment? Question number 63, answer is B, canine. Most common cause of loss of abutment teeth in case of overdenture is caries, periodontal disease, endodontic complications, accidents, and trauma. So in this case, the answer is B, 64B, because already the abutment teeth what we have saved, they are already most of the times they are periodontally compromised. Most of the abutment teeth of overdenture. So they can undergo further periodontal disease, and therefore the answer for 64 is B. After how many days of extraction, immediate dentures can be removed during the night? Answer to 65 is D, 7 days. Answer to 65 is D, 7 days. How much time is needed by extraction socket to complete its calcification? So proper sorry, excuse me. How much time is needed by extraction socket to complete its calcification? It's approximately 8 to 12 months. So question number 66, the answer is B. Question number 66, answer is B. Which of the following is or are common adverse sequelae to single complete denture treatment? Natural tooth wear, denture fracture, both of the above or none of the above? The answer to this is both of the above. That is, there is natural tooth wear because natural dentition is opposing your artificial dentition. Okay, so and denture fracture also can occur because natural dentition has more forces that can be applied, therefore it may cause denture fracture also. So the answer is C, both of the above. In which of the following cases artificial teeth can be tried in before extraction? Permanent immediate partial denture, temporary immediate partial denture, both of the above, none of the above. So trying cannot be done for a immediate denture, as I told you before. So the answer to this is none of the above. 68D, none of the above. Okay. Question number 69. Conditions which favor fracture of single complete denture base opposing natural teeth are heavy anterior occlusal contact, deep labial frenal notch, high occlusal forces due to strong mandibular elevator musculature. Answer to question number 69 is all of the above, that is D, all of the above. All of the following are present in combination syndrome except downgrowth of maxillary tuberosity, extrusion of the lower anterior teeth, papillary hyperplasia. All of them are there except, so all A, B, and C are all clinical features of combination syndrome. So the answer to question number 70 is D, none of the above. D, none of the above. Which of the following is or are associated changes in combination syndrome? The question number 71, also the option is D, all of the above. All of the above. Overdentures are best given on which abutment? Only canines, canine and premolar, canine and first molar, molars only. The answer to question number 72 is canine and premolar. Okay, canine and premolar. Purpose of acrylic template in cases of immediate denture. Trimming of jagged bone margin is the answer. 73B. Major drawback of metal denture base used for single series. Metal denture base, okay. Difficulty to reline, increased weight, acrylic does not bind, can cause injury. So metal denture base cannot be relined. So the answer for question number 74 is A. Major drawback of mandibular single CD opposing natural dentition, operation of natural teeth, fracture of mandibular denture, difficulty in achieving bilateral balanced occlusion or abrasion. Now they're saying major drawback is difficulty in achieving bilateral balanced occlusion. Because there are natural teeth present, it's nearly impossible actually to obtain bilateral balanced occlusion until unless you do a lot of changes in your shapes of the teeth, then yeah, maybe possible. 75, the answer is C. Now we finished with the MCQs for the part 8. We will tackle some revision MCQs. Let's see what all we remember from all the units what we studied of complete denture. Okay. A resilient silicone denture lining materials are superior to plasticized acrylic resin as A. Bond strength with dentures increase. They remain resilient for a short time. They do not support fungal growth and tissue adaptation is better. So silicone denture are superior to plasticide because they do not support fungal growth. 76, the answer is C. The terms most closely related to each other in recording JR are face bone centric relation, hinge transfer protrusive guidance, hinge transfer incisal guidance, protrusion records, and condylar guidance. The answer to 77 is C, hinge transfer and incisal guidance. Question number 78, passive impression technique involves. It's a very old chapter what we dealt with almost a few weeks back. I hope you'll remember passive impression technique, meaning it is the one which does not put any pressure or minimal pressure. That is which material which is used in passive impression is impression plaster. So the answer to question number 78 is C, impression plaster. Before an arbitrary face-bone transfer record, the dentist must determine the axial center of rotation of condyle. Okay, question number 77, C. Question number 80, an imaginary occlusal curve that contacts the buccal and lingual cusp tips of the mandibular molar teeth are called as. Imaginary occlusal curve that contacts buccal and lingual cusps of mandibular molar teeth is the curve of Wilson. 80D. 80D. Rich sonus in denture patients may be associated with gaping, malocclusion, overextension, or lack of retention. Rich sonus may be most commonly because of malocclusion. Okay. Overextension of the mandibular denture base in the distal area will cause dislodgement of the denture during function as a result of the action of masseter, buccinator, pterygomandibular raphe, or superior constrictor. Mandibular overextension, it is in the distal area they're asking. Okay, so which muscle is acting over there? It is definitely the masseter. So 82, the answer is A. The following material is used for making impression in flabby ridge. The answer is A, alginate. Impression material of choice for OSMF patients. Addition silicone, plaster of Paris, ZOE, and conditioner silicone. The answer is A, addition silicone. 84A. Increased vertical overlap in anterior teeth is compensated by increased condylar guidance on articulator, increased curve of speed, decreased cuspal inclination, or flattening curve of speed. The answer to question number 85 is increasing curve of speed. Jaw movement in Bennett shift is anterior, posterior, medial, or lateral. We all know that Bennett shift is a lateral mandibular movement. So answer to question number 86 is D. Monsoon sphere has a diameter of 8 inches. So 87, the answer is B. Mediolateral curve is Bennett curve, curve of Spee, Wilson, or reverse curve. Now, there's nothing called as Bennett curve. Curve of Spee is an anterior-posterior curve. Curve of Wilson, yes, is a mediolateral curve. Reverse curve is also a mediolateral curve. But the most common answer or the most appropriate answer over here would be your Wilson's curve. So we are going to mark C, 88. The answer is C, okay? 89. During recording jaw relation, protrusive records are useful for establishing condylar inclination on working side, condylar inclination on both sides, recording centric relation, or recording condylar inclination on balancing side. It is for recording on both sides. So 89, the answer is B. 89, the answer is B. Question number 90. Centric relation is defined as, the answer to 90, question number 90 is B. Anterior and superior most position of the condyle in glenoid fossa. Anterior and superior most position of the condyle in glenoid fossa is centric relation. Maxillary cast is attached to articulator by using phase 4, changing incisal pin, functional record, or clinical record. The answer to this is by using phase 4, that is 91A. 91A. Which articulator is based on arbitrary theories of motion? The answer to this is C. 92. Monsoon's articulator is based on arbitrary theories of motion. So the answer to 92 is C. Monsoon. Question number 93. Atwood order 4 indicates. Okay, now this also we studied in one of the first few lectures. Let's just revise. Atwood's order 1 is pre-extraction. Atwood's order 2 is post-extraction ridge. Atwood's order 3 is well-rounded ridge. Atwood's order 4 is knife edge ridge. Atwood order 5 is low well-rounded ridge. And Atwood's order 6 is depressed. So therefore, Atwood's order 4 would be option number C, that is knife edge ridge. Residual ridge resorption shows a directly proportional relationship with 94, the answer is C, that is anatomic factors, because both damping factors and bone formation are inversely proportional, okay? Directly proportional is only anatomic factors. Cupid bow shape of the posterior palatal seal is due to? It is due to the posterior nasal spine. 95, the answer is B. Question number 96, the force of attraction between like molecules is called as adhesion, cohesion, coherence. It is cohesion. Like molecules is called as cohesion, that is 96 is B. Dash was first to describe the extremes of mandibular movements. Geisy, Posselt, Tryman, or Johnson et al. The answer to this is B. Posselt. 95 B. As age advances, mandibular ridge in posterior region narrows, remains same, widens, or none of the above. The answer to question number 98 is widens, that is C. Articulator was first described by Gritman, Garriott, Geisy, or Guchet. The answer to this is Garriott. Articulator was first described by Garriott, that is B, option B. And the last question for today is Silverman's closest speaking space utilizes. The answer to question number 100 is B, that is S, J, and Ch. All these three sounds are used by Silverman to describe his closest speaking space. So answer number 100, the answer to question number 100 is B, B, okay? So we come to an end of the entire unit of complete denture today. We finished 8 parts, which was quite extensive. We have completed around 400 MCQs already, okay, 50 MCQs for each class. So there is a lot to revise, there's a lot to study. So please, I hope you all are studying this unit, all right? So I'll see you all for the next time. We will start with removable partial denture, and we will take the classes one by one for removable partial denture. You all can revise removable partial denture, the first few chapters, introduction, diagnosis, components, and parts I'll be dealing with in the next class. So please revise that and come. Okay, thank you.